Welcome, everyone. We're just going to give a few minutes for everybody else to trickle in, and then we'll get started. All right, welcome everybody. I'm really glad you guys are here to join us today. My name is Zainub Dhanani, and I'll be moderating the third session in this webinar series. I'd like to thank the AAMC and all of our partners on this project, the Docs with Disabilities Initiative, the Stanford Alliance on Disability Inclusion and Equity, Medical Students with Disability and Chronic Illness, and Disability in Medicine Mutual Mentorship Program for partnering with us on this project. I'd also like to thank Lisa Meeks from the Docs with Disabilities Initiative and Amy Addams from the AAMC for their partnership in developing today's training. Just a bit of signposting to situate us today in the broader arc of this work. So across this series and at LSL this year, we've been moving deliberately from evidence to tools and now to practice. So our first webinar, webinar 1, focused on the research foundation. Webinar 2 centered on the guide itself. At LSL, we went a step further and emphasized partnership, specifically how learners, faculty, institutional leaders work together to determine appropriate accommodations. We encourage you all to revisit webinars 1 and 2 if these are topics of interest and to assist with building your knowledge. Today, we look to extend that work by examining how accommodation decisions are carried forward through policy, procedures, through documentation, communication, and training, and then continue to build on this work in webinar 4 and the workshop webinar 5, where you'll be invited to create processes for your own programs. There's a phrase that's often used in systems work. Implementation is where dreams go to die. What it really captures is the gap between good intentions and sustainable practice. Medical education can be really messy, but the good news is that we've put today's session together with the explicit goal of helping navigate this particularly tricky terrain. Before we go further, I want to pause for a quick poll to help us understand the challenges you all face in your own contexts. So for the first poll, what communication or implementation challenges around accommodations show up most often at your institution? There's no right answer here. This is simply just to help us understand the realities that you all are navigating and to anchor today's discussion in your lived experience. Let's take a look at our word cloud. So we see accommodations, resistance, parents, students, faculty coming up. I see implement, discrimination, partners. As we go through this webinar, I encourage you to keep the poll results in mind. Where do you see these challenges showing up, and where could small strategic shifts make the biggest difference? With that, let's start with the tool that makes shared understanding possible, the Clinical Accommodations Guide. Take it away, Matt.
Thank you so much, Zainub. So as we get started, I'll just put up a hypothetical. Why did we need standardized language for clinical accommodations in the first place? To that point, in clinical education, accommodations are often approved and communicated using vague or inconsistent language, and that lack of clarity has created real problems across the nation, especially for our learners navigating high-stakes clinical environments. So, from the professional experiences, we're learning from our colleagues that even the most directive accommodations or perceived directive accommodations of, let's say, periodic breaks was being communicated in multiple different ways, both at an institutional level and throughout the nation. And that variety created widespread inconsistency, reinforcing the need for a standardized framework for accommodation language. So I'd like to be clear that what we were noticing was not a lack of goodwill, but rather a lack of shared language and shared understanding. Students, faculty, and disability resource professionals were often talking past one another, even when they were aiming for the same outcome. So that gap is what prompted the Delphi study that was published in Academic Medicine in October of 2025. Quickly after publishing that article, we realized the paper alone was not enough. The paper itself tells you what accommodations reached consensus through our engagement and our panels. The Clinical Accommodations Guide tells you how to use them. We created the guide alongside the paper because schools told us they needed more than a list and also aligned with best practices. A list in and of itself is not effective in order to help institutions understand some of the meat and potatoes behind the accommodation determination process. As a professional myself, as a DRP, and our colleagues nationwide, we need context. We need framing, and we need tools to support real-world decision making. With that being said, as we move forward, the guide includes brief applied sections. Those sections include information on the interactive process, legal foundations, clinical accommodations, professionalism considerations, communication tools, accommodation letters, and implementation and documenting processes. You can find the guide linked alongside the Delphi publication. We'll also drop a link in the chat before the end of today's session. I would encourage you all to revisit previous webinars that focus specifically on these items. They're really important resources and guidance that need to be implemented in medical education. I'm not just saying that because I was included as the writing team for the guides and the articles. I'm saying that because it is critical that in order to fully understand what we are doing, we must have that context, and that's why we're here today to discuss those pieces. With that being said, I'm going to pass it along to my colleague, Sarah.
Thanks, Matt. And so as Matt pointed out, that standardized language is a huge step forward. It helps us clearly and consistently communicate, but language alone doesn't always translate into action at a clinical site. So we want to do another poll here. The question reads, are accommodation processes formally documented at your institution and available such that every person responsible for implementation or organization would know the process and their role in it? So if you go ahead and scan the QR code here, please choose an answer to that question. So it looks like we have some results coming in. Some folks, it looks like a lot of No, 61% no, and 39% yes. Okay. So hopefully then we have an audience here who's ready to learn. And some of you that said yes may still pick up some nice tips from today's session. So we want to pause at this moment here and ground ourselves for the next few slides in the context of what you're going to see. So on one side here, you have strong policies, good intentions, and well-written accommodation language. On the other side, you see implementation, what actually happens at the clinical site on a real rotation with real constraints. That space between the two is the gap. And that gap is where institutions are most vulnerable. It's also where students are most likely to experience harm. This is where things break down, not because people don't care, but because there's no clear path from approval to action. The student becomes that bridge, carrying information back and forth, negotiating with faculty, and troubleshooting barriers in real time. When the gap is left unaddressed, we see delays, inconsistencies, and confusion about roles. We see different answers from different clerkships, and students are left absorbing the stress and the risks of the system. So the goal of this process is to build something across that gap, clear steps, shared responsibility, and documented guidance so students don't have to do this themselves.
Speaking from the learner perspective, this gap between obtaining accommodations and seeing them implemented is one of the most frequently shared challenges for disabled learners in clinical education. And the reality is, when learners' accommodations are not being properly implemented, they often don't feel empowered enough to self-advocate, and similarly are unsure who is responsible for making sure that their accommodations that they were approved for are actually implemented in practice. And so for the learner, this can manifest as just accommodations truly not being implemented as approved. But oftentimes the outcome is one where accommodations are implemented, but the implementation brings on new concerns, such as situations where a student's privacy regarding their disability and their accommodations is unnecessarily violated, situations where the learner has to repeatedly remind the preceptor or their team about their approved accommodations and their use of them, or even situations where a learner uses their accommodations as approved, but then later realizes that they're being penalized in their evaluations for using those accommodations, not because the accommodation itself was problematic, but because of breakdowns in communication across the spectrum that lead to those events. And in each of these situations, the learner is forced to pull their focus away from their clinical learning and navigate securing access to clinical experiences and fair assessment for their performance. And this not only creates additional stressors for the student, like Sarah mentioned, but also imposes additional barriers to seek out learning opportunities and mentorship during their clinical rotations that's so critical to their medical education experience.
Thanks, Zainub, for the reflection. It's important to consider how all of our actions impact our learners. So throughout, we'll keep coming back to Dr. Dhanani for these reflections. Okay, so let's look at this in practice. Say a student needs additional time to chart in their clinical rotation. The Delphi study helped us understand that detailed language is needed to communicate this, while the guide helps us to understand how that decision is made. So let's say we have an example of clear accommodation language, like, and next slide, please. Thank you. So here's an example. Students will have access to the clinic from 6:30 to 7:30 a.m. before scheduled shifts and will be granted secure VPN access to Epic on a university-issued laptop for after-hours charting. This language is clear, but does not fully instruct others on how to implement. So, if an accommodation like this is handled informally and only communicated to the student through an accommodations letter without more context, it puts the student in a really, really difficult position. Next slide, please. So here we know that the student then becomes the messenger. They're the one who has to bring that letter to each clerkship and explain what it means in practice. That may turn the accommodation into a negotiation. the students asking for access, clarifying logistics, and troubleshooting barriers, often with faculty and staff who may not even be familiar with disability processes or who may interpret the request differently from site to site. This is something that's been repeatedly identified as poor practice. Accommodations really should not hinge on a student's ability to advocate, persuade, or renegotiate their access at every rotation. And here's where potential harm happens to both students and faculty, because without that shared process, implementation becomes really difficult. So on the next slide, we're going to provide a little more context. So in an email or other communication that goes to the parties, so here's an example of some additional language that can clarify to clinical leaders and help them understand how the accommodation might be implemented. It reads, the Disability Office has worked with IT to secure VPN access to the general hospital system for post-shift charting. However, rotations where access to the building may need time restricted will need to extend time or assign someone to admit the learner. If your site has no employees in the building in advance of the student's assigned schedule, please reach out to Disability Resources to identify an alternative mechanism for accessing charting responsibilities. Anyone reading this or hearing this knows exactly what's approved and how to carry it out. With this, faculty are not left guessing. Schedulers know what to do, IT knows they're involved, and the student is no longer responsible for translating the accommodation into action. So, even with this additional information, we challenge you to consider that even more information may be needed to fully codify the process. The reasoning behind the accommodation matters too. Documenting why a decision was made, what factors were considered, and who was involved creates continuity. If a new DRP takes over the case or someone is covering temporarily, they're not starting from scratch. This is also incredibly helpful when future requests come in. Being able to look back and see how a similar decision was handled, under what circumstances, and with what kind of safeguards, often makes future decisions faster and more consistent. Building this kind of institutional memory enhances processes and fidelity. We're going to take a look at another example here. So overnight call is a great example of why this kind of process matters, because it often comes up and it can be complicated. Overnight shifts can be physically demanding and can exacerbate certain conditions. We know at the same time, though, that they often need to be looking at essential learning outcomes. So we need to think about things like admissions, handoffs, and clinical decision-making when resources are limited. So when the question is posed, it can't simply be, can a student do overnight call? We need to consider how, in this process, we preserve the educational goals while addressing the functional barrier the student's experiencing. So the guide clearly outlines the steps required to determine this accommodation, while the Delphi study highlights the importance of using precise, concrete language. Therefore, language used to communicate this could be as follows. Student requires 2 12-hour weekend shifts and 2 early morning shifts from 5 a.m. to 1 p.m. in lieu of overnight calls. This accommodation works because it does several things at once. It specifies exact timing so schedulers do not have to guess. It preserves curricular integrity by naming the learning goal, exposure to admissions and handoffs, and it signals roles and responsibilities. The clerkship director confirms equivalency, and the scheduler can flag no overnight. So the level of clarity in our decision-making is important and helps us as institutions resist reinventing the wheel every time. If we don't document the reasoning behind the decision, why it was approved, we can quickly turn back into a negotiation. So what counts as equivalent? Who approves it? How do we make sure the student's still meeting the learning objectives? Without documented reasoning, accommodations drift, and with it, they remain consistent, defensible, and aligned with standards. This also allows schools to make sure that their decisions and decision-making are clear, consistent, and defensible. With requests, the DRP should be able to show historical decision-making, including who was consulted, the learning objectives, and the competencies that were considered in the decision, and why that decision was made. So now we want to talk a little bit about the next step, which is implementation guidance. This is what gives the accommodation structure and makes it sustainable. It answers the practical questions: who is responsible for carrying it out, where it gets implemented, and how it actually shows up on the schedule. In this case, the clerkship leadership may be responsible for identifying rotations or services where the alternative shifts can be scheduled without compromising those educational requirements. The clerkship coordinator may be the one responsible for ensuring that the student's schedule reflects the approved shift structure and is finalized prior to the start of their rotation. A really easy way to operationalize these things is through a RACI chart. In the chat, let us know if you've ever used a RACI chart. So what is a RACI chart for those of you who have not? Well, a RACI chart stands for responsible, accountable, consulted, and informed. And it's a simple matrix that is used often in project management to delineate the roles and responsibilities around a certain endeavor. When we say responsible, we mean who is the person that actually does the work. Those under the A, or accountable, include those individuals who ultimately own the decision and the outcome. C stands for consulted, and that includes those people who provide input before decisions are made. And finally, informed are the people who need to be kept in the loop once things are decided. The relevance here is that accommodation breakdowns don't typically happen due to poor intent. They occur because everyone assumes someone else is handling it. So on the next slide, we took the case and we wanted to map it out as an example in a RACI chart. So you'll see the roles and responsibilities for implementing an approved accommodation might unfold as follows. The Disability Office plays a central coordinating role. They document the accommodation approval and the rationale behind it. They serve as the primary point of contact if questions arise and about how the accommodation should be implemented. The clerkship director then reviews the proposed alternative shifts or modified scheduling to ensure they continue to meet the clerkship's educational goals. Once the director confirms that the plan maintains educational equivalency, then they offer formal approval. The clerkship coordinator or schedule takes responsibility for implementing the approved schedule. This includes ensuring consistency with existing processes and communicating expectations clearly to the clinical site. Clinical site leadership also has an important role in the process. They support the execution of the approved schedule and ensure that the student participates fully in the designated learning activities of the rotation. If challenges emerge, such as questions about equivalency, scheduling feasibility, or meeting learning objectives, the leadership should consult the Disability Office for guidance. It's essential that the student is not asked then to justify, renegotiate, or coordinate their accommodation at any point during the rotation. While our example here focuses on structural roles, RACI charts should also include the learner's perspective. To help us understand how this approach promotes sustainability and provides support for all parties of a leadership standpoint, we now turn to Dr. Cobbs, who offers us insight from a student affairs leadership perspective.
Thank you very much, Sarah. So both Matt and Sarah have so very well outlined why having this kind of conversation is important, and Zainub has pointed out the relevance of the impact on the learner. I'm also going to note very quickly that our first poll pointed out that formal processes for documenting and operationalizing these type of procedures, I think about 40% of those who are here said they had some type of formalized process that was readily accessible, processes and procedures, policies, and about 60% no. So I say that in front of saying, I'm now going to take a few minutes to review and ideally further ground 3 fundamental reasons why educational leaders need to and frankly should support having strong processes and infrastructure in place with respect to providing clinical accommodations. Doing so preserves institutional memory and the processes related to providing accommodations. It reduces risk. And thirdly, well-defined and operationalized accommodations can potentially serve as faculty development tools, particularly in complex clinical settings. And so I think we can all agree or recognize that the clinical education environment is in fact inherently dynamic. Faculty rotate in and out. Administrators change their roles over time, sometimes frequently. Disability resource professionals do move on. And in addition to those kind of potentially changing variables, when accommodation decisions and processes live solely in one or perhaps a few different individuals' email inboxes, archives, or only their personal notes, well, then every accommodation consideration in that type of setting, intentional or not, can unfortunately force the institutional players responsible for providing said accommodations to start over. And so I would say that the result of that kind of procedural looseness, if you will, is foreseeable. Delays, inconsistency, and unfortunately, most likely, some level of unnecessary stress for the learners we're trying to support. So documenting your institutional processes can help prevent those type of what I'll call unforced errors, and also creates, as Sarah has previously outlined, institutional memory by capturing what is done, why it's done, and how it was implemented. And so when a learner returns to a particular clinical training site, or a similar accommodation request might come up in the future, or someone new simply steps into a role that requires them to provide or support learner accommodations, there's existing work for them to start from. They're not trying to reinvent the wheel, if you will. Once again, faculty and staff aren't guessing, and students aren't paying the cost potential of having such uncertainty be present in the system intended to support them. To put a more fine point on it, this level of consistency does matter when accommodations may have nuanced or possibly uh, novel decisions or implementations attached to them. So when the why of an accommodation is captured again within a process or procedure, and not just the what, well, then future teams can understand not only the context, but perhaps more importantly, the safeguards and considerations that shaped said decisions. And so once again, instead of, as has been mentioned, guessing, relitigating, or potentially defaulting to the most conservative option available, any possible new decisions or needed adjustments that may be indicated can be built upon prior work with not only confidence, but more importantly, consistency. So moving forward then to looking at, again, why having written policies are important, an important component of successfully operationalizing disability inclusion. And specifically, I'm going to talk about written processes. They clarify how stuff gets done. One easily and readily recognizable or identifiable example of such a process or policy would be one outlining how accommodation letters are distributed. So such a process or procedure would include how the flow of information is managed, who needs to know, how notifications are managed, and who is responsible for each step in said process, essentially what Sarah said with regard to the RACI process or the RACI model. So outline processes can also specify needed checkback systems that should be built in. So institutions can not only confirm that accommodations are actually working as intended, but also make sure that ownership is present and explicit with regard to the checkback system, eliminating ambiguity about who is responsible for implementing each step in the process. Clear policies will also help eliminate confusion for things like who is financially responsible for providing approved accommodations, how appeals and grievances are handled, and how the timing of requests for things like accommodations on high stakes assessments such as OSCEs, or even requests for support for step one accommodations are going to all be managed. And so when such processes and policies are written out and frankly, openly shared with those who need to know, expectations are transparent, decisions are consistent, and access is not left to chance. Now, unfortunately, one of the most common consequences of not having clear, unwritten processes would be inconsistent decision-making. Similar requests may get different answers depending on who's asked, when the question comes up, or quite simply, how busy the system is on any given week or day. And such inconsistency can trigger what I would call unnecessary escalation. Not because anyone is acting in bad faith at all, but simply because people are actually trying to resolve a real problem with uncertainty in real time. Inconsistency can also show up as late-stage conflict. A learner may arrive to an exam late and told may arrive to an exam and told that an accommodation they were expecting has not been implemented as anticipated. Separately, a student may receive a professionalism citation for following what they understood to be an approved accommodation or alteration to a policy. And the reason why the citation comes up is because, unfortunately, that approved accommodation or alteration was not clearly communicated to all the right people, those that needed to know that such an accommodation existed for that learner. And the result, learner, faculty, staff, all possibly go into crisis mode. And the opportunity for a smooth resolution, which to a situation that most likely was caused due to a misunderstanding or potentially a drop communication, a closed communication loop, may all be well out the door at that point. And so this is where effective policies and procedures are actually protective and beneficial. So the greatest vulnerability for both learners and institutions sits in that gap that Sarah described, that gap between decisions, communication, and implementation. Whereas clear, well-defined processes and policies narrow the gap. They reduce the risk of misunderstandings, prevent inconsistent policies and implementation of practices, and ultimately, ideally, limit unintended harm. So to close my particular comments here, if I could have the next slide. From an educational leadership standpoint, both student affairs leaders as well as academic and educational affairs leadership must be aware of, understand, and proactively support the disability accommodations process at their institution. This kind of work absolutely cannot be siloed. When leadership is aligned, all parties, learner, faculty, disability office, and administration can all be on the same page. And the goal of having such shared understanding is that each learner's accommodated clinical situation can be executed with confidence, and the institution can have with confidence in knowing that the institution has the infrastructure and capacity to support accommodated learners successfully and effectively.
Thank you so much, Dr. Cobbs. Um, as many of the participants on the webinar might currently be thinking to themselves, okay, that's a lot of really great information, uh, but how? Which is also swimming through my head constantly as new practices consistently evolve and there are new details and information that consistently emerge within our field. So, what does that infrastructure that Dr. Cobbs was talking about actually look like in practice? And in some ways, there's not necessarily one direct mold that you must follow. However, there are some core constructs that we want to reinforce. That infrastructure includes clear workflows that define roles and responsibility across offices. Faculty should know who to contact with questions. Learners should know what to expect at each stage of the process, and disability resource offices should have consistent pathways for engaging clerkship leadership. That infrastructure also includes standardized documentation and language, such as accommodation guides that translate needs into functional terms relevant to clinical education. It also includes leadership oversight and accountability, where deans and institutional leaders routinely review processes, address barriers, and reinforce expectations that accommodations are part of educational excellence, not an exception to it. And finally, that infrastructure includes a culture of shared responsibility, where supporting accommodations is seen as integral to learner success and patient care, not as an individual burden placed on a single office or faculty member. That being said, we move forward. And so far, we've focused on how policies and processes protect learners and institutions. And this guide builds on that. But it also offers practical teaching tools for our programs, not only our faculty, but also our leadership and our administration. It supports professional communication by giving faculty shared appropriate language for talking about accommodations. Instead of guessing what to say or avoiding the conversation altogether, faculty have a clear framework to rely on. The guide also helps establish accommodation norms. It shows what accommodations look like in real clinical settings and reinforces that they're part of standard educational practice. As we move forward, while standardizing operating policies are essential for sustainability, flexibility, particularly at the implementation stage, is important. Clinical environments differ, rotations vary, learners' needs and institutional practices may change depending on structure and how they interact with clinical sites. Several key disability-related items should have clear implementation plans in place. If they don't, even well-written accommodations can break down once students hit the clinical environments. What processes should be in place at your institution? So from this, we look at first, there needs to be a defined process for accommodation letters, how they're distributed, who faculty notifications go to, and who is responsible for acting on them. When it comes to the RACI chart that Sarah explained earlier, that's the accountability component. Faculty shouldn't be caught off guard, and students shouldn't have to guess who needs to know. Testing is one area that also needs structure. That includes OSCEs, simulations, and NBME exams. So that could include shelf exams, CBSE, or other applicable assessments. The process shouldn't be consistent, or it should be consistent, so accommodations aren't renegotiated every time the assessment format changes. There also needs to be a plan for durable or accessible equipment and assistive technology within the clinical sites. It should be clear what's available, who provides it, and how it shows up in both classroom and clinical settings. When it comes to specific accommodations or specific accommodation themes within the clinical settings, the first one being leaving clinic for medical appointments. If it's an approved accommodation, there should be a clear process so it doesn't turn into an informal negotiation or potential professionalism issue, which could be solved just by promoting clear and consistent communication. Another area, as Sarah mentioned, overnight call alternatives. If a student has an accommodation related to call, everyone involved should understand how that actually plays out in the schedule, not just that it exists on paper. For interpreters or captioning, for our students who may be deaf or hard of hearing, logistics matter. Who requests the service, who confirms it's in place, and what happens if something falls through. All of those components need to be decided ahead of time. And finally, there has to be a check back system, not one that waits for something to go wrong, but a built-in way to ask whether the accommodation is actually working. Without that, problems can stay invisible. When these pieces have clear implementation plans, the burden shifts off students and onto the system where it belongs. So now we have another poll. As Zainub stated at the beginning, in March, we're going to be hosting a workshop webinar outlining 3 processes, and you can help us choose which ones to assist us with deciding that. So if we go to the next slide, now the link is in the chat for those of you who haven't been able to get to the poll just yet. As individuals complete that poll, just highlighting a clear horse that's pulled ahead in this race, it seems to be check back systems. In other words, how do we know it's working? Because ultimately, no news is no news. We don't know for sure if it's good news or bad news, and to leave it up to assumption can create some uncertainty. And I'll be honest, this notion of checkback systems, a lot of times, even for my own institution, this can be done on a case-by-case basis. We do not have at current a formalized process of consistently checking back on a structured sequence. And that is something that I'm working on seeing whether or not can be implemented and how at my institution it would be effective. Because ultimately it is really challenging to Drop everything you're doing to quickly address any concerns in a reactive manner. It creates a lot of disruptions to our work. So having those checkback systems from a proactive nature helps build in some of those planning opportunities, which can make all the difference. So when it comes to another process that we previously discussed, it was one of those processes on the list in regards to letter distribution. When it comes to notifying clinical accommodations to our clerkship sites, I want to just highlight our processes of the individuals on this webinar today, because each of us handle it a little bit differently. What I want to state is that I firmly believe there is not one singular best practice that all institutions must adopt. Rather, I think there are multiple models and multiple promising practices. The reason I mention that is because ultimately we have to do what is right for our institution. And we base those determinations based upon our structures and what is most effective, not only for our faculty and for our students, but what is most effective to creating equal access within the clinical environments. And that being said, I will start with my process of distributing clinical accommodation letters. I work at WashU in St. Louis School of Medicine, and for our clinical practices, I am a centralized point of communication to distributing those notifications. So this is more of a centralized model where at the start of the clinical rotations, I create a proactive structured mechanism that approximately 12 weeks prior to a student engaging in their clerkship activities, I will send a notification to our clerkship leadership. Parallel to that notification to clerkship leadership, I also send a notification and reminder to the student. The reminder to the student outlines what has been communicated, who that information has been communicated to, and what their responsibilities are. From there, the clerkship team will wait until the student engages with them to understand, does the student want to implement the accommodations that they've been made aware of? At that point, the student theoretically will engage, and in practice also does engage to have conversations. Those conversations are not just, yep, I want to implement my accommodations. Thank you so much. Have a good day. Rather, those conversations are geared towards addressing uncertainty within the clinical experience. For one, yes, it is to saying, I would like to engage and utilize my accommodations, but then it's to saying, who do I need to make sure that I'm keeping in constant communication and awareness? It's also, what is the setting of a clinical experience? What should I know as the learner in order to effectively navigate my disability access needs that may be more personal, that's not formalized in an accommodation? And then also, who will be made aware of this? Once the clerkship director sends that notification to the clinical educators, what does that mean? Does that mean that everybody's going to get my information? And the answer to that question is no. So then it is who specifically? It is my chief resident? Is it my physician attending? Or is it someone else on the floor? And ultimately, the answer to that question depends on the specific need. However, all of those questions are answered during that engagement with clerkship leadership that occurs throughout the sequence of our clerkship process on an ongoing basis. Consistently, that is of a process landscape. It's something that we do have checkbacks for to making sure it's working both for our students and our clerkship leadership to then understanding what types of tweaks and changes we need to make on an ongoing basis. So now I want to pass it along to Lauren to highlight some information regarding her process.
Yes, thank you, Matt. So I'm going to make this pretty direct. At TTUHSC School of Medicine, students are primarily responsible for communicating about their disability and sharing their letters of accommodation regarding any approved accommodation. So while we do have a Office of Student Disabilities, yes, Office of Student Disabilities, that officer gives the letters of accommodation to each student, and then they are responsible for sharing their LOA with all relevant faculty and staff who should know about and or expected to operationalize said accommodations. And so within this model, the clear upside, I would say, is that this way of distributing LOAs takes the pressure off the general system and places control squarely within our students' hands. Students decide who they disclose to, when they do it, and how much they wish to share about either the disability or the accommodations they're requesting. So for students who are comfortable with self-advocating, this can be very empowering, arguably, and also give them a real sense of ownership over the process. I'm also going to defer to Dr. Dhanani as she's going to further comment from a learner's perspective, the pros and cons of this particular model.
So I wanted to chime in a little bit and just share kind of at my institution, we do something a little bit of both. So we avoid neither a solely centralized nor decentralized process. For us, sharing accommodation information is important. And we also recognize that sharing disclosures for students and having sort of the ability to oversee their information can feel personal, sometimes political. And so disclosures we want to make sure are informed by students. And so sometimes that means I'm handling all the accommodation, communication with faculty and sites. Other times it means I'm strongly supporting the student behind the scenes, sharing their letter, but giving them space to have some conversations and disclose to preceptors themselves. And often it's some version in the middle, but the point is that we're balancing two things. So we want to make sure we're always reducing barriers to disclosure, but also preserving the student's right to control their own information as they decide. And so that requires coordination regardless. We don't want students felt like they're navigating this alone. So we plan together and build a process that honors agency, but also really creates a lot of support.
Thank you, Matt, Dr. Cobbs, and Sarah for sharing your models. So thinking again what this looks like from the learner perspective for students, the decentralized model that Dr. Cobbs discussed, it does give students full control over their information. They are deciding who to tell, when to tell them, and how much of their information they want to share. And again, for like Dr. Cobbs noted, for students that are comfortable with self-advocating, that autonomy can feel very empowering and very protective. And it also allows students, the additional benefit of tailoring conversations to specific clinical context and relationships within the clinical space, rather than kind of relying on a blanket approach. And when paired with clear and precise accommodation language, it can help students communicate their needs confidently without kind of traipsing into that realm of feeling the need to over-explain or overshare. On the other hand, in these situations, the burden for that sharing sits almost entirely with the student. And that can be really challenging for some. They're responsible for initiating the conversations, explaining their accommodations if there's any confusion, and addressing any pushback that they may encounter. And this is in a high stakes environment for students with real power dynamics as they're being evaluated for their performance. And so this can be fairly exhausting for a lot of students, and especially when disclosure has to happen repeatedly as preceptors change, residents change, sometimes even within every few days of a rotation, and then of course between rotations. And it can also be a particularly challenging experience for students who don't necessarily have, the skills for self-advocating that they've developed yet, or who may on their own be struggling with their disability disclosure and identity. And that burden of self-disclosure may actually dissuade them from disclosing at all and utilizing the accommodations that they need to fully experience their clinical rotations. And so in these situations, access can end up depending less on whether the accommodation itself is reasonable and more on how comfortable or skilled a student is with that self-advocacy. And so without strong kind of guidance regarding implementation, students are left to troubleshoot problems on their own that really would be better served for all being handled by the institution. And so ultimately, self-disclosure or disclosure through a DRP or kind of a mixed system like Sarah described, every single one of those can be the right choice for different students in different institutions, but really having a clear structure of support for the dissemination of accommodations information and implementation of those clinical accommodations is what's most critical. That clarity and having that framework is what allows learners with accommodations to feel confident in their ability to access the accommodations that they were approved for and seek support when navigating any barriers that may come up throughout the process. And so we've covered, quite a bit of ground today, and we want to give a little bit of time for questions and then share what we have coming up for you. So we've mentioned a couple of times that we have a couple other webinars coming up. So this webinar will be recorded and it will be sent out. And in that follow-up email, you will also receive information for webinar 4, which will focus on the student experiences and perspectives on the Clinical Accommodations Guide. And then there will also be a webinar workshop on March 5th, which with further information will be coming in that email as well. We are also placing a link to the survey in the chat. And that survey will help us kind of glean kind of how this webinar went and any feedback you all have for us for future planning as well. So we'd really appreciate everybody taking the time to fill that out. I also want to give a moment to just thank our speakers, Sarah Traino, Dr. Lauren Cobbs, and Matt Sullivan, as well as again thanking Lisa Meeks and Amy Addams from the AAMC, who have both been phenomenal, and our partners, Medical Students with Disability and Chronic Illness, the Docs with Disability Initiative, the AAMC, Disability and Medicine Mutual Mentorship Program, and the Stanford Medicine Alliance for Disability Inclusion and Equity, for all of their help in creating this guide and in this webinar series. With that, I'd like to transition over to give the rest of our time for any questions folks have.
I see a question already in the Q&A, and I will read it, and then if someone's feeling like they're dying to answer it, it says, would the clerkship coordinator be the correct contact for discussing the accommodation implementation plan? If not, then who? Matt?
Yeah, I'll go ahead and jump in with my favorite answer. It depends. Um, and I say that not to be flippant, but to highlight some of this variability and why I said there is not one best practice. There are promising practices that really span the landscape. When it comes to my conversations with my clerkship leadership, sometimes I will go to our clerkship coordinator, and how we define that role is they do a lot. I mean, truly, when it comes to implementation of site schedules, where students are going, when they'll be there. But one aspect of implementation that is so critical for the clerkship coordinator to be aware of is that notion of, okay, are there any site exclusions that we need to be aware of for this student? Does the student need alternatives to overnight call scheduling, things to that degree? So those pieces really go to the clerkship coordinator to help with unrolling that responsibility. Sometimes it's also then the clerkship directors. So within my communication, that 12-week prior notification, it goes to both my clerkship. There's a clerkship director, associate director, and then coordinator. It goes to all three of them as the leadership team for the clerkship. And then from there, if they have any questions about implementation, they know to reach out to me.
Thank you. And so there was another question that got kind of bumped over we want to highlight. And it was sort of a second part. First, will the presentation be recorded? Yes, you all will have access to that. But with the letter distribution, is the recommendation that the system or school be sharing out the letter to all the faculty and students that the student may encounter in the clinics? Are there concerns about sharing more information than is needed, especially if the schedules and faculty change?
So I think this can vary, and I'll defer to Matt and Sarah and Dr. Cobbs regarding how they've done it. But I will say from the learner perspective, I think sharing it to all faculty or residents that a student may encounter can often kind of start to trickle towards students feeling like their information is being shared more than is absolutely necessary. So for example, a program could have maybe 30 to 50 residents in their internal medicine program, right? And if the student's only working with 4 or 5 of those residents, there really isn't necessarily a need for all of those residents to be aware of the student's disability accommodations, or even though the student has accommodations. But having those individual residents aware, and any of the faculty the resident is working or the student is working with aware, would be valuable. And I'll defer to Sarah and Matt, what you guys' thoughts are on that as well.
Sure, sure. I'll just add, I think this is where the RACI chart can be really helpful in making sure that you know who are the sort of the main individuals who you consult with and can identify sort of those need to know people. And that may be an ongoing process. And part of the challenge we had today is every school is so different and how every school, how leadership is structured, who's doing what. I know we're a regional campus model, so there's a lot of people involved. And so you really need to work expertly to decide, who's here and needs to know, and how does that information trickle down effectively. And so it's important to sort of establish out that process. And I want to kind of tie in one other question in the chat here, which is how do you create that consistent plan of communication and follow-up? And I encourage that person and others to join that March 5th workshop, because really that's an opportunity to individualize and create that plan for your institution. We want to give you lots of answers. And as we sort of developed out this webinar, we realized how even the four of us had such different experiences with our institutions. And so it's difficult to be prescriptive in this realm. There's a lot of nice frameworks we are utilizing and considering, but I really think that'll be an opportunity to collaborate with one another and start to develop your own plans of, who are the people that would be included, and how might you develop sort of plans to sort of circle back to the student and circle back to the clerkship director and consider how to sort of best practice implement these. And thank you, Dr. Meeks, for adding the registration in the chat. Dr. Cobbs, anything you'd like to add before we wrap up?
Yes, very quickly. I'm just going to strongly sit in the position as a faculty member and educational administrator. Everyone doesn't need to know. So it's having clear workflows that identify who is appropriate to know about a learner's accommodation and ensuring those individuals do in fact know. And that's where the work and the magic happens. And I'll kind of leave it there.
That's a great place to end it. So thank you all again for being here. We appreciate your time. We appreciate your patience, especially with the technology that always plays games. And so we are so happy to have you and hope to see you at the next webinar.